Perfect.
Have us sit down.
Okay, you tell me what you want. I don't remember how we did it last time. Sorry.
It's recording right now.
Okay.
So it's like if speaking, it's recording.
Okay, and then just to advance the slides.
Right? Like
Okay.
right here.
All right. I'm gonna move here so it's easier to see everybody. Exactly. Hi everyone. I'm Deepa Chand. I'm a pediatric nephrologist, and today I've kind of got a little bit of a potpourri of renal topics for you. As we go along, I will point out things that are likely to appear on the boards based on historical context, and certainly if there's a question, please feel free to ask because I don't want you guys lost the rest of the lecture. So first, I'm going to talk about proteinuria. I like to throw this slide up there because this test is actually still seen. Anybody know what test this is? Have you ever looked on your labs and it says SSA, sulfosalicylic acid? Yeah, that's what this is. And all of you are probably going, I've never known what that is, and I didn't know how to interpret it, but it does show up on the labs. And what you do is you take 1 part urine to 1 part sulfosalic acid, and it's a qualitative test for proteinuria. We're going to talk about the different tests for proteinuria. You guys are very familiar with the dipstick test, where you literally have negative charge proteins that bind to a pH sensitive indicator. The big thing to remember about the dipstick is the most common cause for a false positive is actually alkaline urine. And that has shown up on the boards. They will give you a scenario, and you have to and what I usually recommend is just look at that pH, because otherwise in clinical practice you really don't look at pH too often, right? So look at that pH. If it's an alkaline pH, kind of circle it, and you can see a false positive with it. You can also see false positives if somebody's undergone recent urologic testing and received dyes, or with certain antibiotics, specifically penicillin. Remember, the dipstick, again, qualitative test, just like the sulfosalicylic acid test. The best quantitative test is a protein to creatinine ratio. Again, and I know you guys do the preps, and this is shown up on prep, and it often shows up on boards too. What is the best quantitative test to measure for proteinuria? It is no longer a 24-hour urine, so do not pick that test. The reason is because people don't do it accurately. If I asked you to make sure you collected every void for 24 hours, it's hard to do. And you ask a child to do it, it's even harder. So the best test is actually a first morning protein to creatinine ratio. That sometimes does not show up as an option on your test. And if that's the case, put random protein to creatinine. That's the next best answer. 24-hour collection, you'll still see people do it. Normal, just so you know, is less than 4 milligrams per meter squared per hour. And I put that there just for your reference, not for say for the boards. Textbooks will still quote to biopsy if the protein excretion is equivalent to greater than 800 milligrams per 24 hours. In clinical practice and in more recent literature, we actually won't biopsy till they're above 1 as a ratio, 1 gram per gram, or greater than gram on 24-hour urine collection. It's very important to recognize once you've done your test and you've got a positive test for proteinuria, what are possible etiologies. And the first thing you want to make sure is it real? Things that cause transient protein especially are exercise, fever, cardiac disease, seizure activity because of the muscle release, muscle breakdown, and certain medications can certainly do it as well. Orthostatic proteinuria is a very practical thing that you really do need to know about. And I put this reference for you because I want to show you that the publications go back into the 1960s and 70s. The prevalence of this is actually about 5%. And your classic prototype will be the teen or preteen athlete that comes to your office for a physical. It's generally speaking in the afternoon after they've exercised or after practice because that's when it's convenient for them. And you will dipstick their urine and it'll be positive for protein. That's your prototype. The old school and what's published is that you do 3 first morning voids because, again, if you've had increased protein release due to exercise, or even the theory being that there's an alteration in venous return to the heart, and that's what causes the protein, and it's a benign finding so you really want to use the first morning void where the urine was produced when the patient was in a supine position. So the urine's produced while they're laying down Good idea to have them empty their bladder before they go to bed, and then that urine was made when they're supine. Check that. If it's negative for protein, you're done. It's that simple. If you really want to be methodical, do it 3 times. But quite frankly, you get one negative, it's negative. What was really kind of cool is the way that they discovered orthostatic proteinuria. It's a little anecdote, but it'll help you remember it. Is in World War II, they had military recruits in whom they did physicals in the afternoon, and all of them had protein in the urine. And these were healthy 18 to 22-year-olds, and everybody's going, why would they have protein in their urine? So they had them doing urine samples, jumping jacks, laying down, upright, I mean, you name it. And what they found was when they're supine, they don't have it. And what was really cool, this particular study in the 70s was actually a follow-up to those military recruits. And this is a completely benign condition, no follow-up necessary. So that's what's very important. And you have to reassure your parents because this you will see very commonly in clinical practice. So now you've ruled out all of those things and you've said, okay, this is real proteinuria. Now what I do? There's a couple of different ways to think about this. And what I like to do is kind of figure out where the protein is coming from. Is this a tubular, i.e. small protein loss? Is it an overflow situation or is it glomerular in origin? Tubular implies that you have a defect in the proximal tubule because what you've done is you've exceeded that threshold for of protein excretion. That can be seen lead poisoning, that's a big one. So lead intoxication, cystinosis, and Wilson's disease. Those are your top 3. So that's again very important to know, especially for your boards. Overflow won't be on our boards because we're pediatrics, but for those of you that are med peds, multiple myeloma and myoglobinuria are your etiologies there. And glomerular is where we will focus most of our time because that's an impairment in the actual membrane, glomerular basement membrane. These are some of the etiologies for persistent proteinuria that will come from a glomerular origin. Nephrotic syndrome, as you guys are aware of, focal segmental sclerosis, membranous nephropathy, membranoproliferative, i.e. MPGN, congenital anomalies, dysplasia, obstruction, polycystic disease. The reason I put those there is that you will see glomerular etiology of protein loss once you progress to chronic kidney disease. This is one condition, or this class of conditions, you can get both tubular as well as glomerular losses. There is an entity known as benign persistent proteinuria, although that really is a diagnosis of exclusion and really a diagnosis in a way made in retrospect. Nephrotic syndrome. This is very, very important. The reason it's important is the boards does like the diagnostic criteria. And the way I want you to think about this is what happens in your body. Okay? You start peeing out protein, so you start with proteinuria. Then your blood oncotic pressure decreases, so you have hypoalbuminemia. Okay? When your blood oncotic pressure decreases, then fluid goes into the interstitium, and therefore you have edema. We're all clear, right? If you think of it that way, those are the 3 diagnostic criteria for nephrotic syndrome, and you won't get them wrong. Hyperlipidemia it's kind of the 4th unofficial criteria. You do not use it as a true diagnostic criteria, but it's seen universally. And I'm talking cholesterol levels of 600-700. So it's not subtle. And again, it's just an impairment in lipid metabolism. We won't get into that for the purposes of this talk, but just something to keep in mind. Incidence is there. Mortality risk is actually nowadays very low, and we'll talk about that. And some of the causes you guys are already aware of: minimal change disease, and then all the different GNs as well. I put this in here for mostly reference, and a couple of the things that I just want you to take home, and the biggest thing I want you to take home here is that low C3. That will show up on your boards in one way, shape, or form. If it doesn't, call me and I will buy you dinner, because I guarantee you that will show up. And it's really important because of the nephrotic syndromes, MPGN. It's on your board, see? I guarantee you. There are 3 renal conditions that will give you low complement levels. I'm going to digress for just a second, but this I will say probably 5 times during this talk because it's that important. MPGN, lupus. Anybody give me a 3rd? Acute, a little more specific. Acute GN. I might put it another way. What's the other term? Post-strep, post-infectious. Exactly. Acute GN is the proper term. So if you do see it that way, know that they're all the same. So yes, those are the three things, but those will show up on your boards. Minimal change historically is the one that responds to prednisone, so that's the one we worry the least about. And that's how we make the diagnosis often is by giving a trial of steroids and see if they remit. And if they remit, most likely it would be minimal change. And the reason we call it minimal change is if you were to biopsy somebody, you're going to see minimal changes on their biopsy. Quick little algorithm for those of you, really this is more from a clinical standpoint that I like to use this algorithm. It's very well published as to what to do if somebody presents with proteinuria. And a lot of it depends on if they're symptomatic or asymptomatic. You take the asymptomatic, that's the classic one that I just talked about in terms of it more likely to be orthostatic proteinuria. So you want to check your first morning voids. Those are negative, you're done. If they're not, those are the general basics. This is actually taken from a published source where 24-hour urine was recommended. I would not recommend that. These days, I would actually put that as a first morning virgin creatinine. If you see somebody who does present with edema, less than 12 months of age, straight to a biopsy because we really it's a potpourri of what we could be dealing with. So we go pretty much straight to a biopsy under that age group. Some would even say under 18 months biopsy, but again, I'm going to go based on the agreed upon published literature. If they're older, we generally give a trial of prednisone, 6 to 8 weeks. If they completely remit, great. Your presumptive diagnosis is minimal change disease. If they don't remit, go to a renal biopsy. Very important. This has shown up on boards. I got to tell you, in recent years, I don't think it has, but you tell me. Common complications of nephrotic syndrome include peritonitis, specifically with strep pneumo and E. coli. So you always have to warn the parents if there's fever, vomiting, abdominal pain. They need to seek medical attention pretty much immediately. The other big complication, thrombosis, pulmonary embolism. In more recent years, I've seen sagittal vein thrombosis in the head. Those seem to improve spontaneously, but again, you just kind of keep that in mind as well. But thrombosis and infection are your two biggest complications with nephrotic syndrome. And the reason for that is because you're losing so much protein that you start losing indiscriminate protein, and so you lose your immunoglobulins as well. So that's why. All right, I'm going to stop there with proteinuria just because we have a lot to cover. Any questions there? Okay, let's go on to hematuria. This is very important. I know nobody looks at urine other than nephrologists anymore, but anybody know what that is? Red cell cast. Red cell cast. Okay, very important to know. And a brown cast is very important to bring up, and we're going to actually talk about that as well. A brown cast is actually more likely to be an acute process. This is actually a cluster of red blood cells and their cast. So, um, anybody know what it signifies? I'm going to take it one step back. Yes, you're right. Glomerulonephritis. More importantly, nephritis being the fact that there's blood in the urine, it's of glomerular origin. So when you say glomerulonephritis, be conscious that it's of glomerular origin and not tubular. And it makes a difference in your thought process. The incidence is actually quite high. It's about 0.1% for gross hematuria and 1 to 4% in the general population for microscopic hematuria. So again, this is something you're going to see very commonly. Couple of different ways to think about hematuria. I'm going to give you two. One, that it could be glomerular, as we just talked about. It could be interstitial. It could be vascular in origin, so extra-renal per se, or it could come from the urinary tract. And another way to think about it is this, and this just kind of lists you the most common etiologies. I like this slide just from a board perspective in that, again, just thinking about, it's in the glomeruli, it's in the interstitium, vascular, and then it's in the drainage system. And if you think about it this way, it'll help narrow the differential down. Another way to think about it is not, this is a little bit more of a simplistic approach, but quite frankly, it's a faster thought process approach. So when you're cramped for time on the boards, this works a little bit better, is if it's painful or not painful. If it's painful, you've only got three things on your etiology list, and that makes your differential really quick UTI, trauma, easiest ones to rule out, and then you've got kidney stones, hypercalciuria, and we're going to talk about that, but I like to lump that together as urinary mineral abnormalities because I think that's more of an accurate term because we now know, contrary to what we used to know, that's not just hypercalciuria. That's one of the etiologies, but it actually could be hypocitraturia, citrate being a protective component of the urine, could be hyperoxaluria, and it could be hyperuricasuria. This is the one time I will tell you that 24-hour urine collections are still the standard of care. And the reason is you can't do timed urines because your excretion varies based on the time of day. So you really want to get a good 24-hour picture. So we actually do a 24-hour urine, and if I'm doing one, we're going to do it for everything. So you want to get a calcium, you want to get a creatinine. The purpose for the creatinine has nothing to do with their renal function. What it does is it tells you if it's a complete 24-hour collection. So it's 15 to 25 milligrams per kilo per hour is your standard creatinine excretion. And if you are less than that, they didn't do a 24-hour collection. So, and if you're higher than that, oftentimes it may mean they did some vigorous exercising or, that type of a thing. So that's why you're getting the creatinine. So it is very important to do because I get that question a lot. You want to get the uric acid, you want to get the oxalates, and you want to get the citrates. The question I always get asked is, what about imaging if you're doing an evaluation? And really, the only thing an imaging is going to help you with is, are they passing a stone now? So that's more of a good of a test for the ER. So if you have somebody that comes in and you're suspicious of stones and you're suspicious that it's obstructing, and you want to know where it is, that's when you want to get some imaging. An ultrasound can miss 30 to 40% of stones depending on where where the stone is. So ultrasounds not so helpful. If you've got severe hydro, it may be helpful, but other than that, it's not going to help you. So a spiral CT, otherwise known as a helical CT, is the test you want to do. The difference between that CT and an ordinary CT is that your cuts are finer. The cuts are 2 to 3 millimeters in size. So if it's a 2 millimeter stone, it's probably not going to hurt that bad. So you're actually going to get most of your stones that would be of clinical significance on that imaging study. So that's about the only time you want to do it. So on your boards, when they ask you, that's not the first test you want to do. You want to check their urine if you're doing more of a chronic evaluation. The way that you treat it, most of the time, it's drink more water. Current recommendation is 64 ounces of water a day. Now I know I do that because I'm a nephrologist and I consciously do that every day, but let's face it, most of you don't. Most of the general population, huh? Yeah, I know. But when you think about it, okay, you take a water. Okay, that's an extra big water bottle. Take a normal size water bottle. It's only about 3 of those a day. Not that bad, right? Yeah, that one's 15 ounces. Yeah, it's not that much. The classic setup, we are seeing actually a huge rise in children with kidney stones in this country, and that's the All American Diet. And I love giving this conference over lunch because the classic American diet, right? High salt, low fluid, low water, high caffeine. So for those of us that drink pop, have a candy bar and a bag of chips for lunch, which nobody's doing, which is great. You just increase your salt. There you go. And chocolate, remember, is a huge source of dietary oxalate, so that increases your risk of stones. So again, it's a lot of dietary patterns in the U.S. and especially with fast food and especially with eating on the go. So we are seeing stones on the rise. So this really is important as far as clinical practice goes. Citrate is a protective substance. Yes, drinking things like lemonade will increase your citrate excretion, which will help, but most people can't drink that much. So sometimes we do end up alkalinizing the urine with really a citrate supplement. Hyperoxaluria is something that you do have to investigate a little bit more if they do have it. It could be idiopathic, just from dietary, but it can also be a sign of underlying disorders like oxalosis. So it's something we do investigate. And hyperuricasuria as well. And you see, common themes: increasing fluid, increasing alkalization are the two big ones. UTIs, I'm not going to spend a lot of time on because all of you in this room know how to treat UTIs. Just make sure the specimen is adequate. Bags are for garbage if they're not potty trained. Look at your sensitivities. And under the age of 6, still consider the renal ultrasound of ECG. I doubt they're going to ask you too many questions on this on the boards because, quite frankly, you ask 10 pediatricians, you're going to get 5 different responses of how to do this. So it's not likely to be a high yield board question. But to be complete, it's got to be there. Now let's talk about some of the fun stuff that does show up on boards. Acute glomerulonephritis, one of my favorites because that always shows up on boards, and I don't know why, but they like it. IgA, and then for some reason they like hereditary nephritis, so we'll spend a few minutes on that as well. Acute GN often is associated with hypertension, edema, and abnormal renal function. This is a diagnosis we make in retrospect. And the reason we make it in retrospect is that you know about the infectious exposure. You know that there's low levels of serum C3. So it's very important to get that test when they come to the ER, when they come to your office. The one test you should get is that complement level. And the reason that that's so important, of the 3 conditions that we talked about, we all know them, right? I got to do it. Sorry, guys. You'll thank me for it later. 3 conditions that cause low C3. You got it. All right, I won't keep asking it. So of all those conditions, this is the only one in which that C3 level will return to normal without any intervention. So that's why I say it's a diagnosis in retrospect. So when you see nephrologist notes, we will write presumed post-infectious glomerulonephritis until that level comes back to normal. So if that level doesn't come back to normal, then you biopsy and figure out what's going on. Have I had it where it's still a post-infectious GN? Yes. And some are just a little slower to recover, but at that point you need to rule out especially lupus, and PGN too. So that's the caveat there. IgA nephropathy. Worldwide, this is the most common cause of painless hematuria. It's important because there is a percentage, small, and it's closer to probably 10 to 15 when you take worldwide and some adult cases into it, will progress to end-stage renal disease. This is the way they will describe this to you on boards, and this is the way you should think about it clinically. The patient will present with gross hematuria, just like they will with acute glomerulonephritis. How do you know the difference? Well, the timing. Exactly. The timing is how you're going to know. With IgA, it's at the same time as the gross hematuria. With post-infectious GN, it's going to be that the infection was about 2 weeks before. So on your boards, because that's how they like to get you on that question, that's something you want to see is the timing of it. And that's shown up in prep too, I believe. So you guys should be familiar with that. Aggressive cases, everything's been tried, quite frankly. As a nephrologist, we end up throwing the book at them. We do steroids, we'll consider plasmapheresis, because what you want to do is just mitigate the disease process so it doesn't progress to end-stage renal disease. Alport's hereditary nephritis is the other term for it. Big one, they'll give you the clinical scenario, the high frequency hearing loss. That's the buzzword. Once you see that, you know what it is. Males are more often affected because the most common type is X-linked dominant. Therefore, in the genetic family tree that they like to put on boards, you won't see the father to son transmission like this. So kind of keep that in mind. And they do like those little boxes and circles on boards with. You know what I'm talking about, the pedigree chart. The boxes in the circle. That's why I stick with nephrology. Males will often have more aggressive renal failure, so they'll be at end-stage renal disease somewhere in the second decade of life. You've got to screen these patients. Even if they don't have hearing loss off the bat, they might develop it, and they often will. So it's one of those things that you want to screen them as well. All right. Are we good so far? I know I'm going through this fast. You guys will have the slides, so if there's any questions, and Shirley's got my email, so if you guys have any questions, let me know. I want to talk for a minute about casts because, again, this is something they like because this is not the things they like on boards are things that are not questioned, things that are not controversial. This is not controversial. Glomerular, you'll see red blood cell cast. So anything that causes glomerular disease, IgA, the acute glomerulonephritis, lupus, hemolytic uremic syndrome, you'll see casts on the urine. Non-glomerular, think lower tract, think non-renal, and think tubular. So non-glomerular causes. So again, Stone's UTI, lower tract, right? Sickle cell, tumors, trauma, bleeding, not renal, right? So think of it that way. I like algorithms. This actually is a lot easier to read on this. So when you guys print it out, it actually reads out pretty well. An algorithm for gross hematuria, and I give you one for microscopic hematuria as well, just for clinical practice, as far as your standard tests to get. But of course, you're checking CBCs, renal function panels, urines, things like that. They often will like to throw in a test where you have gross hematuria and there's no red blood cells on the actual UA microscopic. So in that case, think myoglobin, rhabdo. Don't think renal. So, and actually, I'll get those type of consults about a couple of times a year, where they had gross hematuria and there's no red cells on the microscopic. What do I do? So that's something you want to kind of keep in mind as well. And this goes through that. Um, Treatment is just like anything else. You got to figure out what it is. Um, if it's isolated microscopic hematuria, we follow that. We don't tend to biopsy that. And the reason is, what are you going to do differently? Nothing. You're going to follow those patients. There's nothing to do. So this is really in those situations where you have a glomerular etiology, or you have proteinuria, or you have hypertension, or you have impaired kidney function. Something is going on. And I just kind of gave you some of the more common ones. Remember, post strep or post infectious is usually self-limited. That's the big one they like you to know. And a lot of these they won't ask you about because it's controversial. If they do ask you about the treatment of any of these and there's proteinuria present, the knee-jerk response should be an ACE inhibitor. That is now standard of care. Is ACE inhibitor. ACE inhibitor. Yep. You can use your angiotensin receptor blockers as well. So those are fine to use too, but that's what they'll ask. That's the type of stuff that they'll ask. They won't ask disease specific. Okay. I'll see for awake. 8-year-old who comes in with brown urine for one day. Became ill 3 days ago. He lost his appetite. His parents thought he looked puffy around the eyes for the past 24 hours. They didn't notice his urine looking different until today. He's otherwise healthy, immunizations, a little pale, maybe a little puffy in the eyes, weight's at the 50th percentile, blood pressure's a little high, um, everything else is normal, and maybe a little edema. What are you guys thinking? IgA. Very good. Very good. And yes, because it's exactly at the same time. They throw the hypertension in there to throw you off a little bit. If he's got a little fluid retention, it could be from that. Plus, how many kids are very calm going to the doctor's office when they don't feel well? So it's something you want to follow. It's something you want to note. But this is the kind of stuff they like. I don't know what happened. Sorry, I lost my slides. I think we were there. Okay. Sorry, I don't know what happened. Exactly. So IgA. We're good. Okay. Got one other case for you. 4-year-old routine physical comes to your office, and you know what? Ever since he's been a baby, we've seen some brown urine every now and then. He's otherwise healthy, normal physical exam. UA, yellow urine, many red cells, a few casts, and trace protein. There's his creatinine, his hemoglobin. What are you guys worried about? Upwards. Very good. Very good. Yes. And especially the cast. Remember, because you're going to think glomerular in origin. So, because at first glance, you almost thought this was going to take you towards IgA, didn't you? And then you get that little tidbit of information. So read your questions very well. All right. I love this one. Sorry, I'm a nephrologist. Remember? Anybody want to make a diagnosis? Wow. All right. So I heard polycystic kidney disease. I heard multicystic dysplastic kidney disease. And I'm going to tell you that you are looking at an ultrasound of one kidney. All I can tell you, based on this is there's cysts in the kidney. That's it. We cannot make a diagnosis based on this ultrasound. You need more information. So let's give you some more information. Let's talk about polycystic kidney disease first. Autosomal recessive polycystic kidney disease. They like this one. And the reason they like this one is because it's tried and true is why. But it presents in infancy. Now there are some cases that we will see later in life in the adolescent years that are more mild. So it is possible, but historically you will see this in infancy. You don't need to know the gene, but that's more if you want to know. And what it is, it's a defect in fibrocystin, and that defect disrupts normal ciliary functioning in the kidneys. The clinical manifestation, and this is the important part, is that you have renal and hepatic manifestations. Congenital hepatic fibrosis. Those are the buzzwords for ARPKD. You can have hepatic involvement in autosomal dominant polycystic kidney disease as well. That's going to be a little bit of a different variety because it's more hepatic cyst. Congenital hepatic fibrosis, classic buzzword for ARPKD. When you see Potters, and you guys have probably seen this, especially in the NICU, it's basically when you have severe renal and or hepatic involvement in utero to where you have pulmonary hypoplasia as well. Severe cases of Potters are not compatible with life as well. If you survive your first month, you do great. There's still a significant mortality risk in the neonatal period. Often it's liver or kidney. Generally, it's not both, although I've seen it where both organ systems are severely affected. You will see tubular dysfunction. You'll see, because it's tubular, you'll see tubular dysfunction. You'll see electrolyte abnormalities. Specifically, you'll see hyponatremia. You may see hypokalemia as well. Decreased urinary concentrating ability. Remember, infants can't concentrate their urine as it is, so you have to take that with a little bit of a grain of salt. An adolescent who can't concentrate his urine is very different than an infant. They are going to have a decrease in the ability to acidify the urine, and they might also have pyuria. Hypertension, and a lot of times it's because it's a mass effect, because their kidneys are so large and they're cystic that you actually sometimes will see vascular compression. There are probably some vascular mediators that are activated as well, but those haven't been as well elucidated as far as etiology goes as well. Liver, we talked about congenital hepatic fibrosis. The LFTs are usually normal, so keep that in mind. So when you see this in a baby, if the LFTs are normal, it doesn't necessarily help you. You do make the diagnosis by ultrasound. You'll see the tiny cysts initially. You'll also end up imaging the liver as well. I'm going to take this back. There are some genetic tests that doesn't capture every type now, but they are quite costly, so they're not necessarily being done in clinical practice. They still run about $3,000 to $5,000 a pop. And they're not definitive. So for ARPKD, we don't do genetic testing as often, but remember, if you're doing genetic testing, you're kind of do the whole lump anyway. Important is counseling, and they do like this question on boards with certain conditions. They may not do it with ARPKD, but they do with certain conditions where they'll say, what's the risk of transmission to the next child? Because that's what they want to know. And a lot of times what they'll do is they'll give you the scenario where this couple has a baby who has congenital hepatic fibrosis and the infant dies at 2 weeks of age. The parents want to know about their risk of the next child. So they won't tell you. It's what I call a double elimination question. They ask you two questions in one on the board. Because you have to know, first of all, the congenital hepatic fibrosis is related to ARPKD, and then what the transmission of ARPKD is. So it's kind of the double whammy, which is very clever if you think about it. But they like those types of questions. So that's why I have this slide to remind me to tell you, with all your genetic conditions, just kind of know what autosomal dominant recessive, all that means. Well, it kills you right away is recessive. Yes, in the infant period. Autosomal dominant, the interesting thing about, and this is why I hesitate, autosomal dominant is the third leading cause of end-stage renal disease in this country. So in adulthood, it's actually a major problem. And it's certainly more common. It's 1 in 1,000. So it's definitely more common, but you're right. In the neonatal period, autosomal recessive is more likely to kill you. You're absolutely right. Now here we do know the chromosome 16 is what's implicated in most cases, but also chromosome 4 can be involved. Um, you have enlarged kidneys, bilateral renal cysts. Now, I say this with a caveat because I have seen autosomal dominant polycystic kidney disease present in utero, even. You'll see cysts. Our ultrasounds have gotten so good that we'll pick up the tiniest cysts, where before we didn't go looking for them in infants. So now we'll see them. So I've actually made this diagnosis at birth in patients. But again, your family history is going to tell you. Dad had it, grandma had it, da 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 da. And so that's how you often will know. But I have seen it in the infant period, so don't let that throw you off. But infant mortality, yes, think AR. These patients can develop gross hematuria, universally microscopic, can develop hypertension, like we talked about. Cysts can get infected, cysts can burst. Those are very, very painful processes and often will need interventional radiology to go in and either sometimes remove the cyst, deroof the cyst. There's a variety of procedures they can do now. Can cause renal colic. I had a teenage girl, beautiful, slender girl who had ADPKD. She was a dancer. And it got to be extremely painful as her kidneys grew to the point where she stopped dancing because of the renal colic. Yeah, but she ended up doing great long term. Went to college, got married, all those good things. But it is something that they often will need to alter their lifestyles. I don't advocate them to do so unless it becomes a severe problem. Pain management now can often help too with the renal colic. I have sent patients to pain management services. You'll see cystic dilations in all parts of the nephron. So I think of autosomal dominant dominates the kidney, takes over the whole kidney. So think of it that way. Pediatrics, you guys don't deal with it a lot because, quite frankly, it becomes a problem in adolescence and adulthood. Extra-renal manifestations, cerebral aneurysms is a big one. And again, they like that one because it's a double elimination question on boards. Hepatic cysts are present. They don't like that one because, again, don't want to confuse it with ARPKD. Cardiac disease, mitral valve prolapse is actually fairly common in these patients as well. For those of you that are mid peds, we do screen for these as well, and a good family history. If we know that somebody had CNS event, you better believe we'll be screening them with MRIs very early on. Colonic diverticular hernias, if they're on dialysis especially, you can see abdominal aortic aneurysms as well. Very important because, of course, that ruptures. They're in big trouble. Multicystic dysplastic kidney disease, MDKD. Yes, exactly. The big key on this one: unilateral, unilateral, unilateral. Polycystic kidney disease, both kidneys by definition are involved. This by definition is unilateral. Okay? They can live a full, healthy, normal life so long as the other kidney stays normal. Okay? So, and actually, it's presumed that about 10 to 15% of the general population has this. And the reason is because when you look at adults, about 10 to 15% only have one kidney. And that's been an incidental finding. They're in a car accident, somebody gets a CT, oh, you only have one kidney. So it's more often been a incidental finding, and the thought is that they may have had multicystic dysplastic kidney. What happens is that you have this enlarged kidney. It's got multiple cysts. It's a non-functional kidney. So because it's a non-functional kidney, what happens over time is that it actually involutes. It basically necroses and dies off, but involute sounds better. The big thing is up to 40% of patients there's up to a 40% incidence of reflux in the good kidney. So that's why I say it's important to keep the good kidney healthy. Now, do we routinely do VCUGs in every one of these? Most people do. Most people do. Some will wait for a first UTI. Otherwise, most people do, and they'll do it in infancy. And the reason is because if it's that high of a risk, you only have one kidney, you want to keep it healthy, get it done. Remember, reflux is something you're born with. If you do the VCUG and it's negative, it's negative. If you do it in infancy, under the age of 1, they're never going to remember. So get it done. So I kind of feel like that's the practical as well as the medical way to go. So that's just the way I usually approach it. The enlarged kidney will involute. We don't, because people ask me, well, if it involutes, do you take it out? We generally don't take it out unless you start seeing a lot of infections in that kidney or if they start having hypertension. Then you might. But as a routine, we do not take out that cystic kidney. Um, One other thing I wanted to mention with this is that later on, as we follow ultrasounds in the good kidney, you'll actually see compensatory hypertrophy. So that kidney may appear a little bit larger than standard, and it's just something for you to know. That's a normal phenomenon. Okay. Hang on, I don't know why some of these came over twice. I'm sorry. Okay. Alports we've already talked about, so I don't want to talk about that one. Sorry. Okay. I wanted to talk a little bit about nephronephrosis, medullary cystic kidney disease. Um, the reason is medullary cystic kidney disease, MCKD, not multicystic dysplastic kidney. That's multicystic M. The K and the D are reversed. Okay, that's what I'm trying to get at. So when you see it, they won't do that to you on boards, but just from a practical standpoint, people get them confused. Medullary cystic kidneys is something that's very different. It's autosomal dominant. It's an adulthood disease. The main thing is that it can lead to end-stage renal disease. A multicystic dysplastic kidney does not lead to end-stage renal disease. So that's why I wanted to make that distinction. I intentionally left some of these slides for you guys, again, more for reference purposes than anything, so feel free to look through those. But I wanted to make that point, so don't get confused on boards if they ask you one versus another, and especially for those of you that are med peds. And they like some of these with medullary cystic, so I want you to have those slides. Talk a minute about reflux, because it is the most common congenital abnormality of the urinary tract. They will not ask you per se necessarily interventions with VUR, but they might ask you about VUR because it's so prevalent. Um, you diagnose it with either VCUG and RNC. That used to be a very popular boards, but when I took the boards, that was on my boards. I don't know if it'll show up again because it's been a while, but the way that you diagnose it, because a lot of people say, well, you see hydro on your ultrasound. Is that indicative? No, you actually have to do a VCUG. The very first time you're looking for reflux, you actually will do a fluoroscopic voiding cyst or urethrogram. Does anybody know why? You won't do a radionucleotide the first time ever. And the reason is on a radionucleotide where you do it, by injecting a dye, peripherally. With a VCUG, remember that you've got the bladder catheter in and you're filling the bladder. So if you have a neurogenic bladder, you're going to be able to diagnose it on a fluoroscopic VCUG. And with reflux, remember in utero, if the baby's been refluxing, then their bladder could be abnormal too, right? If it's high grade. So if they've got a neurogenic bladder, you'll actually see that in that first VCUG. So that's why you do it that way. So that's the test. And they can add, that's fair game on boards. That is very fair game. Renal scarring, this used to show up too. I don't know, I don't like this test. It's a DMSA test. The reason we do a DMSA test, again, you cannot detect renal scarring on an ultrasound. You really can't detect it on any other imaging. The DMSA scan is where you inject the dye, it's taken up by glomeruli. If you don't have functioning glomeruli, the dye won't be taken up. So that's why it's a functional test. And that's why it tells you that there's scarring, because in that area, there's no functioning glomeruli. Now, the one thing you can't tell is if it's old scarring or new scarring unless you have sequential ones. So that's what's so important about that test. So with reflux, they're more likely to be focused on the diagnostics, so that's why it's important for you to know that too. Now, do we always do renal ultrasounds? Yes, but that doesn't help you with this, but it is something we do. And the reason we do it in this scenario is because you want to look at interval kidney growth, and that's easier done on an ultrasound. So there's still a utility, it's just not a diagnostic purpose per se. I'm going to skip this because this is evolving, but that is still the correct algorithm. It's under 2 first UTI. They're still recommending the whole BCG for now. I think it's going to be changing, but we'll see. There's 5 grades of reflux. Grade 1 virtually always goes away, so we just follow them. Grade 2, grade 3 is a little bit more controversial because they still have a better than 50% chance of being outgrown. Grade 4, grade 5 being